Hello, good morning, everyone. I'm Luis Jané here from Barcelona. It's a pleasure to be sharing with you this class and the knowledge that we acquire here in the UIC University. Hope everyone there is good. And today I'm gonna talk about the aesthetic analysis in digital oral rehabilitation. Okay, here I'm gonna focus at the beginning in how we do a general aesthetic diagnostic of a patient, how we go since the outer lines regarding and paying attention on the face, then in the smile, in the profiles, and then going deeper into the smile, later into the tooth, and so on. After that, how we manage and how we define a prognosis and a treatment plan. Two main and super important aspects. Otherwise, it's difficult to decide what to do and how to do it. And after that, I'm going to share some cases and how we manage them, and try to help maybe to understand how is nowadays in Spain and Europe the dentistry, and how we deal with the tools that we have here. To present myself very fast, I come from this university. Okay, this is the International University of Catalonia. In the summer we have grass, in the winter not. But even though here the winters are very warm, here I did my pre-graduate studies. Later on, I have the opportunity, once I finish the degree, to have a collaboration with a university in Geneva, in Switzerland. Also amazing land, very different because it's surrounded by the mountains in the center of Europe. And here the university is very with a lot of investment, so it's very motivated and with a lot of support to do great research, and all the professors there were super famous ones. So for me it was an amazing adventure, an opportunity. I started here learning about the in vitro studies to analyze adhesive systems. And then I moved back again to the university in Barcelona to start my master program in oral rehabilitation, and later on in implant dentistry. Here, this picture is how is the university clinic, and well. So we are going to start analyzing this patient. This patient has many teeth, but he's an ex-smoker of 20 cigarettes. He had a stomach intervention 5 years ago. He works as a mechanic and is a driver of a trailer. So he's mostly all time he's driving the trailer through the country, driving one point to the other. So it's difficult for him to have cleaning maintenance and to proper hygiene. So at the beginning of aesthetic analysis, we start analyzing with these two pictures. Okay, one of it is in totally lateral position, and the other in the front with the patient in normal position. In the frontal picture, it's very important to analyze where is the midline of the patient, to understand if the nose has any deviation or the clavella, and then it's going to be important to fix our dental midline later on. Also, it's very important to mark and define the bipupillar line. Okay, bipupillar line is an important line to understand where we are going to place and where we are going to fix our horizontal plane that is going to be important for the oral rehabilitation. Under the bipupillar line, if we are in this picture, okay, under the bipupillar line, we have the camper plane that is very important because it's going to be the way, or more or less the plane that we will have in consideration when we mount under the articulator to fix the posterior occlusal plane. Then it's important the bicommissural line, okay, to understand if it's horizontal or if not. In this case, if you see, there is a slightly canting to the right of the patient. The other important points to divide the face and understand if the face is a long face, short face, or medium face are the glabella, that is pointed here in the middle, the nasolabial point, that is spotted under the nose, and the mentum, just here. These 3 points are the ones that we are going to take to divide the upper third of the face, the medial third of the face, and the lower third. Regarding this patient, if we see normally these thirds should have similar length, but in this case, if you see, the lower third is a bit longer than the medial and the upper one. That tells us that this patient has a long face. Now we go through the other picture, the left picture, to see the completely lateral view. And in this, the first point, or the first importance that we take in this situation is to analyze the profile. And here the patient has a convex profile. It's important to know where is situated the maxilla in the plane, if it's super forward or backward. That will tell us if the patient has a class 3 with a big big jaw prognatation or frontal position, and that's going to help us to understand more or less the symptoms or the situation that we will have in the mouth exploration. It's important to see that the angle of the nasolabial angle has to be of more than 90 degrees, okay, this point, to understand the support of the lip, and also the mentum shape, to understand how is the chin in this mouth. Having this in consideration, we can see that this patient has enough lip support, but and good mentum shape and a convex profile. That is in our benefit to rehabilitate. All these lines are very important, but it's true that when we are starting dentistry or when we are starting to analyze cases, there are many lines and it's very difficult to interpret what they are telling to you or what's the importance of any of those. That's why I recommend you to get the Fradiani book, okay? If you don't have access to it, I can send it to you by PDF. Just ask Dr. Akram or send us an email and I will send you, because it's super important and it explains very well how is the process and the steps. So after analyzing the face, we are gonna move a little bit deeper into what we love, no? That is more the teeth than the face. And here it's very important to take 3 pictures, or at least super important, the 2 pictures of the extremes, like the rest position and the maximum smile. But normally, when we are taking these pictures with a patient, new patient that we already meet him, and you ask him in front of the camera, smile, they are giving to you the social smile, okay? Because all of us, we know when we smile how much gingiva we are showing or how many teeth we are showing, and if we have something that we don't like, we try to hide it. So that's why it's super important to ask him to do the maximum smile, to analyze how many teeth we are seeing this smile, and if the teeth are long, if the gingivas are okay, and all this information. Here we see that the rest position here normally has to be about 2 millimeters in males and maybe even 4 millimeters in young women. And in this patient, we see that the 2.1, the left central incisor, has proper exposure, but the 1.1 is super extra eroded and is not gonna be useful for us. Then when we analyze into the mouth, we see that the patient, okay, has many of the tooth. It looks like he has some periodontal problems, we will have to see. He has a bridge from canine to canine, lower canine to canine. It looks like it has a bonding 2.2 lateral into an amalgam or a metal crown in the canine, and some missing tooth, posterior tooth, in every quadrant. But most important is that when this patient is grinding, he has no guides. There is no way to make a disocclusion with the canines or with the central incisors. That is super important when we are trying to protect the tooth, because if there are no canine guidance or anterior guidance, the posterior tooth are overstressed and on under pressure or under force much more time than what they should be. So that start affecting the periodontal ligament and the bone surrounding the tooth. In the occlusal view, if we analyze the 2 shapes of the arch, one of them is totally triangular and the other is circular. So this patient cannot bite properly because triangular with a spherical shape is not fitting properly. These things we have to think about them when we are restoring the bridge, for example, or things like this. Because this bridge, the dentist did the perfect scheme, but he should have in mind that the scheme is another one. But the main problem here is that we don't have posterior support. Let's see in the X-ray, what's the situation? We see that even we have a lot of tooth, some of them look a little bit with some problems. Okay, we have some implants and the crown. Let's analyze with the X-rays. We can see clearly a periodontal problem. Some of the tooth are attached just to few fibers, like analyze this central tooth, analyze this premolar, analyze this premolar. All of them has some issues. Let's see if we can maintain them, or we have to extract, or what to do. But if this patient wants to start eating properly and a solution for the future, we have to start thinking what to do. So the beginning list of problems are an uncontrolled periodontal disease and partial edentulism. And before doing anything, the ideal protocol should start with a periodontal stabilization. Okay, we have to clean all those teeth, see how the gums are gonna recede after the periodontal treatment, and see where the margins are gonna end up, and see if any of the tooth clearly we have to extract it, or the ones that are healthy, how we can maintain them, and if we can stop the movement of them. After that, after stabilizing the periodontal problem, we will be able to think about the prosthetic phase. But normally, even if we have to extract anything, the ideal protocol says that we have to clean everything before to avoid any infection and reduce a lot the bacterial problem. So this is a diagram of how is the starting situation, okay, nothing new. And before anything, we follow a lot this article that says, okay, if we have all this tooth here, I went back in the previous X-ray. If we have all these tooth, what we can do about them? I mean, how we analyze if this tooth can stay in mouth or we have to extract it? And this article is very useful because help us to consider how when we can treat or extract or replace a questionable tooth. Okay, and we have to analyze the periodontal thing, then the endodontic, and then implants and prosthetic. So the first thing is to start analyzing periodontally all these teeth or a mouth. Okay, periodontally, how is the proving that? Depending on how is it, we start placing it as a good teeth to do it, or it's a questionable or a hopeless tooth. Okay. After that, if we have tooth with a good prognosis, we can move through the endodontical area. Okay, should it need an endodontical treatment, or if already has an endodontical treatment and we have to redo it to know more things about what to do, okay, or if we have some periodontal images, what to do. And it's very useful. Okay, I recommend you to follow this article or at least read it to understand more or less how we start doing the prognosis or of the cases. Later on, if we have to extract many of the tooth, this other article help us to determine how many implants we can place, or if we have to do a removable prosthesis or an overdenture prosthesis with palatal full coverage, or removable but implant connected, or only implant retained, or depending. Okay, all these decisions are not just my priorities and with my experience. No, there is science that tells us what to do. So after regarding the case, after seeing the reaction after the periodontal stabilization, we decide with the patient to go through a general or big solution, and we had to extract it. Okay, Well, our first option, if we have to extract, could be implants direct to the tooth, if we don't need posterior support, or depending on the length, or maybe we have to put a pink ceramic to design as the gingiva, and that will help. That could be a second option, or the third option to do like an all-on-4 and over denture that we can take it out to clean it. So well, until here are the main general decisions. Okay, hope you more or less will be encouraged to do it. Later on, here the case since here is how we mount it, how we design it, how we wax it up, how we decide where to place the implants, how we are gonna do the provisional teeth, if maybe we leave some tooth to fix a provisional for the healing, okay, and where to place the implants. At the end, the decision was to extract all of the tooth and maintain some strategical tooth to hold the provisional during that phase, create an eggshell provisional, and cement it to the tooth, and that will help us to decide to leave the patient like this a few months until the healing is done and until all the infections are solved. We prefer that in that case than in the other option, extract everything and go for an implant placement, immediate implant placement, because regarding all the inflammation and all the infections, the final prognosis would be better if we do it in a two-stage surgery. This is immediate provisional. To make it a little bit more beautiful, we did one with pink ceramic, okay, to make it more natural. We mount it again. We correct some midline and some aspects. This is the patient with the tooth, okay, and at least he can stay a few months. We correct some things, the incisal exposure, the torque of the tooth, because if we go super outside, it's gonna be a problem. Okay, this is we were at the university at that time, so this is learning curve of the process. At the beginning, anything goes as you planify, and you have to place it into the mouth, see, make some lines with pencil, start deciding, correct everything, wax up again everything, and that's all. It was another wax up, correcting, we mount it again, we create a new one. Well, yeah, and at the end, I want to go, we're gonna finish the case, okay, but once we went to the surgery, and after the surgery, we place the implant, we put some bone, we extract a bad implant, we put some bone, we fix with the key where to place the implants, we remove bone, these surgical pictures, and then we had ready a prosthesis, and after that we place some pins, and then with the implant some posterior, and the best option, we did a pick-up technique. The best option is to make some holes where the implants are, place some provisional screw into the implant, later on place our rubber dam, and do the pickup with acrylic resin. And after that, start relining with acrylic resin. Okay, this is the situation with the acrylic, and then start polishing, 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 polishing. Okay, we want to be this surface smoothest as possible, because the gums have to heal. This material is going to be in contact with the healing phase and the blood and the tissues, so we don't want plaque and dirty to get stuck on it, on the roughness. Okay, more pictures. We screw it into the mouth, into the patient's mouth, and that's the immediate situation after the surgery. The patient went home with this, and after this we just need to heal and finish the case. Okay, now we are gonna move forward, because nowadays we are in the digital revolution. Okay, time ago we were doing dentistry with analogs. At least here in the university, we were doing with alginates, silicones, and nowadays we are doing the everything digital. And here in Europe, is everyone moved to the digital because something crazy is happening, and is that there are many services that are super fast. Like, we have an industry here that its name is Globo, or like Amazon, that you can buy something in Amazon and it's very fast when it delivers here in the city. And these people that are Globo, you buy a pizza, for example, and they bring it to you at home, no, or things like this. So this is because people is getting used to these tools that delivers things so fast. Also, it's happening that people, when it comes to the dental clinic, they are not understanding that we have to wait like 4 months for the healing of an implant, or that things go so slow. They want things go fast and expend the less time possible in the dental chair. And nowadays we are facing different types of oral rehabilitation. Okay, we have the type 1 oral rehabilitation, that is something simple. Okay, just this tooth, the patient came like this, so we have to remove all the decay. We have to do the endodontical treatment, the deep margin elevation of the tooth, because the breakage was under the gingiva, so it's difficult to isolate. And after this, we create the new restoration. No, we make the dental margin elevation, the endodontical treat, then we prepare the endo crown, take the impression, and cement the indirect restoration. Other kind of patients, they need an implant. Here we have this temporal tooth that is moving, and the patient wants to fix a solution. So we place an implant, and immediately we extract the tooth. We place an immediate implant, and afterwards the provisional restoration. After the 3 to 4 months, when the healing is done, if we have placed the provisional, we just need to unscrew the provisional, place the scan body to take the digital impression, and then create a crown, of zirconia crown, where we are gonna cement over it a feldspathic veneer. In this kind of patient, if the implant goes direct to the prosthesis goes direct to the implant, okay, we have to think that the sulcus is very deep. And in this kind of patients, when we rehabilitate, we have to place anesthesia and be very careful of the tissues. And every connection and disconnection of the scan body, of the provisional, of the new definitive tooth, of a new correction of the color of the definitive tooth, this is the implant. So every connection here can bring some bacteria here and start losing bone of the implant. And when we cement it, this liquid is chlorhexidine gel, but the important thing here is to see the whiteness surrounding the implant. Okay, when we screw it, we create ischemia. That's why some implant brands like BTI, they create this like transepithelial thing that you screw it to the implant, and it will give us all the tissue profile, and we're gonna cement the crown over it. That's why in this kind of cases like this, that the implant, instead of going directly to the implant, goes to this transepithelial, we see a different kind of sulcus. Okay, it doesn't has the depth of the other one, and when we cement it, we don't need to work with anesthesia. There is no ischemia, so everything goes fast, and then we close the hole and we put light of polymerization. Okay, the two differences here when we rehabilitate just one implant is to go directly to the implant, but it's true that when we screw this crown to the implant, we are creating pressure over here, and we are bringing some bacteria to the bone. And that said, that as much as we separate the connection of the implant is better in the long term. The other option is to screw this transepithelial that just is not gonna be seen aesthetically. It's just gonna be under the gingiva to help our connections, disconnections, or any problem is gonna happen at this step, not close to the roughness of the titanium of the implant. Okay. Also, a rehabilitation, there is a type 2 rehabilitation. Okay, in this kind of rehabilitation, we are gonna rehabilitate more than one tooth, not just one tooth. In this case, for example, we have a challenging case where we have to change the metallic ceramic crown and the composite crown of the patient, composite veneer of the patient. In this situation, we have to manage different thickness, different materials. So let's see what's underneath both materials to see how is the tooth and how is everything. Here, after the removal, we see that the tooth who has the crown is super dark, is almost black. The other one is okay. So we think, okay, let's try to bleach it. So we create a hole. Okay, here is difficult to understand. Okay, this is a provisional crown, a new provisional crown that we prepare after the removal. But if you see this hole, is a hole into this. We create the hole, we seal the dentin, we seal because this tooth was endodontically treated, we seal the gutta percha, and we ask her to place some bleaching material into the crown to start bleaching at home every day. After the bleaching, we reconstruct the tooth with a post, and we prepare the tooth for a BOPT preparation, okay, in order to separate the gums and have a not 90 degrees feather edge or margin, is more like no margin line, okay, BOPT. In the neighboring tooth, we also do without preparation line. We place a cord to separate, and then we're gonna ask for a veneer cemented over a crown that's gonna opaque the substrate. And here the final situation. Okay, the most important thing is that this crown should have the same thickness of this crown. Other example in a similar case like this is this patient. Okay, she came because she fell down from the bed and she was complaining all life because she breaks the 2.1, and she was complaining all life of his provisional tooth and the neighbor one. And if we see, she has an implant, bad position implant, by the way, and tooth and the rest. We want to see how is everything, how are the margins. So we take out the crown. Take an X-ray to see, okay, the implant is okay. Have to change the crown, but the neighboring tooth that is dark, the 1.1, what's happening to it? And we see that he has a periodontal eye match, but also a calcified root. That's very difficult because if you see in the neighbor tooth here, we can perfectly see the root canal, but in this one it's not possible. To the endodontist, he doesn't like me to send this kind of patient because he will have a tough work to do. He has to reopen the canal and seal here, trying to block all this infection. He did a great job, and we can move for a mock-up restoration to share with her how she can look if we start doing some periodontal elongation of the margins. So she didn't like the veneers, but she liked the elongation. And here we did some periodontal therapy just to lengthen this tooth. And we start after the healing to do the veneer preparation of the tooth, because this is endodontically treated. We can do a crown, or like here we can do a veneer. And at the end we place some veneers in the neighboring tooth, and we finish the case like this. Finally, we end up our communication like in WhatsApp like this. She's sending me pictures of herself, and she finally get married 2 years ago. Now she is waiting for a cycling. She's pregnant and super happy. Then we're gonna face the type 3 oral rehabilitation. These kind of rehabilitations are much more difficult than the other, because in this one all the teeth in the mouth are affected. And in a cases like this, we have to analyze everything very careful. We have to see why things are like this, why it's happening, how we are going to avoid this happening to again. Because he's a young person with a very destroyed tooth, an ugly situation. So he's smiling, this is a smile, we analyze the face, then the smile, and then intraorally. This is the X-ray. We see clearly many problems. And as I told you before, first step is to define the prognosis. I like to spot every tooth in different 3 colors. If it's favorable, green spot. If it's questionable, orange spot. And if it's hopeless, in red spot. That will help me to know which tooth should be extracted before starting anything and start cleaning that infection, and with which ones we have to start analyzing, removing the decay and seeing how they are periodically and how they are restoratively. Okay, if we can restore over it or not. So the main problems here, if you see, are this one. 2 to 2 are the ones that we really need to define if we can keep them in mouth or we have to extract them. So, which starting point do you recommend? In my eyes, we need to start removing all the tissue affected by the decay, infected by the decay. So we start doing it. And we see that, well, not bad. It looks like worse than now, before. So now we have to restore them, and I'm going to show you this restorative technique of the tissue on the margins. It's very, very interesting. Firstly, we place the band with some Heliobond adhesive. Is a special adhesive for composite without fillers, and that will help us to seal everything. Time ago, I was doing these restorations with the rubber dam, the wire, the wedge, but was super difficult. To do them. So, with this technique, we start adding adhesive and etching the enamel and the dentin. Is 30 seconds in enamel, 15 seconds in dentin, and then the 2-step adhesive system. And when you have the adhesive, one very interesting point is to put a little bit of flowable composite and then directly over it before the polymerization to pack all the normal composite. Doing this technique in this kind of cavities, we will avoid to leave some bubbles under the composite. After that, you see it's difficult to remove the bands. We make some light and we take out we have to polish again, to polish everything a lot. With soft like disc, and then with this smoothie composite bar, and we end up like this. Okay, this is the situation. Just finish right after the decay removal and reconstruction. Okay, 2 weeks later, we start analyzing and we see that the margin of the canines should be also to put all the margins in balance. The margin of the canines should be increased a little bit. So we add some compo material and we push up the gingiva with this metallic band. I told you it's a very good technique because it helps leave smooth all the margin and also help us to push the gingiva. And one very interesting tool, because now we are going to communicate with the lab technician, is to make like a composite veneer on the top of the tooth to tell the lab technician how he has to design. Time ago, we were designing with the wax up, but nowadays we have these tools, the ExoCAD. And as you see here, in the 1.1, we give a composite veneer with the patient in front of the patient, and now the lab technician has all the information of the shape, of the position, and the distribution of the spaces and the distribution of the proportions. Thanks to that, it's super easy to communicate and it's super easy to succeed in every mock-up because the lab technician has all the information of the torque, the volume, and everything. You see how they wax up super fast. They start increasing the length, opening the embrasures. Time ago, when we have to do it with the wax up, it takes much more time than here. Okay. So we place the mock-up into the mouth of the patient and we start analyzing a lot if the patient loves it, if the color is correct, if the size is okay, if the plane is harmonic. And once we have this, we start analyzing with him the way of biting. And in these cases where we are increasing the DVO, it's very important to know what's the neutral space, okay, how many millimeters we can increase the DVO, and do a deprogrammation, in this case with a jig, do a deprogrammation to send to the lab technician how is going to be the length of the occlusal veneers. and we start prepping the veneers. If you remember, everything is compo material because the tooth were very affected. So we have a space to start prepping and doing the preparation. We like to do again no margin. Okay, so that's why we are prepping under the gingiva, having in mind not to touch a lot the gingiva, okay, just slightly, and leave no margin, okay, even it's bleeding, it's not a problem. This is the situation, we open the embrasures and leave out the margin, and after, in this picture is after placement of the Teflon cord to separate a lot the gingiva and open the space for the lab technician to be able to design as they want. After the preparation, we are going to place the mock-up again as a provisional restoration. It's very important when you place a provisional during a few days and you are going to leave the patient for a week, 2 weeks, or a few days until the lab technician does the veneers. It's very important to remove all the acrylic resin of the mock-up of the gingiva, okay, to avoid the gingival inflammation. Now the lab technician, this is what he gets. He knows how is the mock-up, what's the shape that we like, and he just needs to fix the margin where he wants. And if he feels the gingiva is annoying a little bit, you will see how he starts eliminating that gingiva. You see here, he starts eliminating it to help to define a much beautiful shape. Okay, you see how he's moved the spawns. Everything is super precise. After this, we send this to the lab technician to mill all the restorations. And this is the day that we take out the provisional. If you see, if we had careful with the gums, they are not bleeding, they are healed. The patient could clean out all very good. And we place the retraction cord again for the cementation. This Teflon tape retraction cord is very easy to place and it's going to separate a lot the tissues. Then for the adhesion, we are going to sandblast the tooth because mostly everything is compo. And if we have to add edge to a bond to compo material, we have to sandblast it. Then we are going to place the rubber dam. Okay, we place 2 clamps in the posterior tooth. We place the rubber dam and the clamp and the adhesion. Okay, after the sandblasting, we are gonna etch the enamel and the composite to clean it everything. We're gonna place 30 seconds. We apply styrene and the adhesive layer. Now this is how we place the veneer. The cement is very important to place it in the veneer and in the mouth. We take out all the excess. We take out the excess of the interproximal excess and everything. And we light cure many seconds. Then we place some glycerin gel for the interface of the compo and the cement. And this is the after the cementation. We take out the cord. Everything is bleeding, it's normal now, and with the blade we start removing all the excess and all the everything. And in the posterior, because we already extract the tooth, we are gonna cement this kind of provisional bridge, okay, to keep the DVO as we thought, and then cement the lower veneers. And this is how it ends up, the beginning and at the end. The beginning and at the end. Okay, so it has been a pleasure to share with you this presentation. If you love it, I can keep doing the next part of the presentation, and hope every one of you is okay. If there is any doubt, please let me know. Okay, many thanks in advance, and it has been a pleasure. Bye bye.